Hi, good afternoon, and my sincerest apologies for being late, but I wanted to hear Charisse. And this meeting was called yesterday afternoon, so I left it at the back after. I just wanted to emphasize that Charisse is one of our success stories. She has been industrious from the get-go, ably backed by a very enthusiastic supervisor, Dr. Off the Hyde, who more and more is becoming my kind, well, not is becoming, I'm realizing is my kind of supervisor. The one that wants to cuss you out for his students, supports his students, pushes for his students. That is what we need at UTT. And I've heard Charisse speak on this topic before, but it had not been, she had not completed her research at that time. So I'm very interested in seeing the final product. And again, as I said, she's one of our success stories in that we have somebody who applied themselves, does something that I think will contribute to the field of diabetes management, and at the same time shows that we can do good science at UTT. So without too much ado, let me introduce you to our MPhil candidate, Charisse Ramkissoon.
Thank you. So, my name is Charisse Ramkissoon, and today I'm going to talk about my MPhil research. And that has to do with creating a glucose insulin pharmacodynamic pharmacodynamic model for use in the treatment of insulin-dependent diabetes mellitus. So here we have a amino acid structure pramlintide, and this will so this will be the focus of the talk.
You don't have to use the pointer if you don't want to. You just hit the arrow key.
You may be touching it. Go to slideshow and then just rest the pointer down. Okay. Oh, it's not a pointer, it's the computer. Oh,
That's not your laptop, right?
no, this is the UTT laptop.
Okay, I think we should start over.
The amino acid structure pramlintide, and this will be the focus of today's talk. We essentially model pramlintide. So why do we want to make this model? Well, diabetes mellitus affects 347 million people worldwide, and in 2007, it incurred a national cost in America which exceeded $174 billion. So diabetes causes both hyperglycemia and hypoglycemia. So hyperglycemia is high blood glucose levels, and this causes 24,000 people with diabetes to lose their sight each year. It causes 180,000 people with diabetes to die of kidney failure each year, 500,000 people with diabetes die of cardiovascular disease each year, and poor circulation increases the risk of legs and feet amputation. And diabetes also causes hypoglycemia, and severe hypoglycemia causes brain damage, coma, and death. So the main problem that diabetics are faced with is the inability to sustain tight glucose control using insulin therapy alone. And this is seen most after a meal. So here we see a meal occurring and a huge spike in glucose that occurs when using insulin therapy alone. So one solution that we found to this problem is the addition of pramlintide, which is an equipotent synthetic analog of pharmacodynamics. It suppresses glucagon release, slows gastric emptying, and increases satiety. And these three mechanisms cause postprandial glucose to be more manageable. So as you can see here, no huge spike occurs when you see it with insulin therapy alone. So pramlintide is available commercially as Similan and is given as either 60 micrograms in type 1 diabetes or 120 micrograms in type 2 diabetics. So the aim of the study is to create a physiological model of a type 1 diabetic patient able to be used in a controller. This model will have a meal disturbance, will have subcutaneous insulin pharmacokinetics, pharmacodynamics, will have subcutaneous pramlintide, pharmacokinetic, and pharmacodynamics. And this is the real novel part of the model. There has been no published models that include subcutaneous administration of pramlintide. So currently there are 2 intravenous PK models done by Coburn and Fan, and Fan also includes a PD model. So remember, both these are intravenous. So in a healthy person, the body has 4 organs that are responsible for glucose maintenance: the liver, the stomach, the gastrointestinal tract, and the pancreas. So in response to a meal, the GIT uses incretins. These incretins are gastric inhibitory peptide and glucagon-like peptide 1. And these cause the pancreatic beta cell to release insulin and amylin. And this is actually a feed-forward action that occurs before a meal. So when the body is in anticipation of a meal, insulin and amylin is secreted. So insulin is responsible for promoting the glucose uptake in skeletal muscle, adipose tissue, proteins of various tissues, and the liver. And the liver is responsible for changing glucose into glycogen and decreasing plasma blood glucose levels. And it also suppresses lipolysis. Amylin, GIP, and GLP-1 slow gastric emptying and promote satiety. This is a feeling of fullness. Insulin and amylin suppress the release of the hormone glucagon, and glucagon is responsible for changing glycogen into glucose, and this raises glucose plasma levels. So another interesting fact about amylin is that it's co-secreted synergistically with insulin. So in this graph, on the left shows plasma amylin, and on the right shows plasma insulin. And these white bold arrows show meals. So after a meal, insulin and amylin are co-secreted synergistically, and they're also secreted in a ratio. So what is type 1 diabetes mellitus? Well, in a regular person, the immune system consists of T effector cells. So T effector cells target pathogens, release cytokines, which destroy pathogens. However, in type 1 diabetes mellitus, these T effector cells instead target pancreatic beta cells. They release cytokines and destroy beta cells. In contrast, type 2 diabetes, insulin and amylin, instead of producing normal amounts, produce too little. So beta cells produce too little insulin and amylin. There's also insulin resistance that occurs in several muscles and tissues. So the body's response to this is to create more amylin and insulin to try and beat up the resistance. But when this occurs, high concentrations of amylin have a propensity to aggregate. This causes plaques. These plaques destroy beta cells. This plaque production is also why amylin cannot be used therapeutically, and instead pramlintide is used. So here shows amylin concentrations in type 1, type 2, and non-diabetics. So in type 1, you can see that it's virtually non-existent. In type 2, it's a lot lower than it should be. This shows beta cell malfunction. It shows that the beta cells are not producing as much amylin as they should be. So what are the long-term complications of both type 1 and type 2 diabetes? It's retinopathy, so blood vessels within the eye die, what within the retina becomes constricted, and so 2% of diabetics become blind and 10% become visually impaired. There's also impaired renal function that occurs, and 10 to 20% of those with diabetes die of renal failure. Neuropathy also occurs, which is the death of nerves, and it's a major contributing factor in foot and leg amputations in diabetics. And also 50% of those with diabetes die of cardiovascular failure. So how do we stop these complications from occurring? The importance of tight glucose control was not fully understood until the release of this study, the Diabetes Control and Complications Trial, which was released in 1993. It consisted of 141 volunteers, and the study of retinopathy, and it slowed the progression of eye disease by 54%. It also slowed the progression of kidney disease by 50% and reduced the risk of neuropathy by 60%. And it also reduced the risk of cardiovascular disease by 42%. As you can see, these are significant reductions. So tight glucose control for diabetics is a very important issue that should be addressed. So one solution that scientists have been working on is the artificial pancreas. This is a closed-loop electrochemical system containing a continuous glucose sensor, an insulin pump, and a control algorithm. So what occurs is that glucose is continuously monitored, and control algorithm signals to the insulin pump when to administer insulin based on glucose levels. This is a continuous cycle that occurs. However, there are many problems that occur with the artificial pancreas. The first is postprandial hyperglycemia, which we spoke about before. The second is subcutaneous to subcutaneous delays and noise. So the continuous glucose monitor and the insulin pump, it was subcutaneously implanted. And the subcutaneous layer lies just below the dermis. That's a fatty layer. Glucose monitoring and filtering also occurs. So the continuous glucose monitor, what it does, it continuously monitors glucose. When it gives you a reading, it's actually an average of data that over 5 to 10 minutes. And then also nocturnal hypoglycemia. So any parent with a child with type 1 diabetics, their greatest fear is for their child to go into nocturnal hypoglycemia. Because of the abnormal levels in glucagon in diabetics, this is a major concern. So here, just the delays, subcutaneous delays that occur. So the absorption of insulin into the subcutaneous layer takes about 50 minutes. And then for insulin to actually have an effect on blood glucose takes another 50 minutes. And then interstitial glucose to plasma glucose takes another 10 minutes for glucose readings. And then there's also an additional transport line of 50 minutes. This is approximately 1 hour and 45 minutes. So long delay. So here are some studies that just prove the mechanism of pramlintide work and occur. So in 2008, there was a study done on glucagon suppression using pramlintide in both type 1 and type 2 diabetics. And as you can see, with pramlintide, glucose levels are a lot lower in type 1 and type 2. Also, a study done in 1999 shows that with 90 micrograms of pramlintide, there is about an hour delay. And that's a pretty significant time delay. And then also a study done in 2005 showed that satiety was drastically increased when comparing pramlintide users to placebo. So overall, these mechanisms cause pramlintide to improve postprandial glucose control. One study to note, which was done in 2012, was a study using closed-loop control with both insulin and pramlintide. And as you can see here, this is with pramlintide, it significantly reduces postprandial hyperglycemia. And this is not using pramlintide in the actual controller. Pramlintide is administered with a premeal bolus of 30 micrograms. That's a small dosage for such a large impact compared to only insulin. Also, one thing to note why this model is important, why modeling is important in general, is because clinical trials are an integral part of the development of closed-loop systems for both safety and efficacy. However, they're time-consuming, resource-demanding, and very costly. So instead, preclinical testing in a computer simulation environment for in silico testing accelerates development. It also facilitates preclinical optimization of control algorithms, and there was actually a glucose insulin model done by the University of Virginia that was approved by the FDA to replace animal testing. In silico testing can also evaluate extreme conditions that you couldn't normally do on a patient for ethical or practical reasons. such as hardware failures, sensor malfunctions, pump occlusions, missed or excessive doses. That's a big one because you can't give 100 units of insulin per patient. But you can test how these different scenarios have an impact on the body without actually causing harm to somebody. And then also significant meal-related carbohydrate discounting. So once again, aim of the study to create a physiological model of a type 1 diabetic patient that we'll be able to use in a control. So before we go into methodology, I just want to explain what pharmacokinetics and what pharmacodynamics are. So kinetics are what the body does to the drug. So this is how the drug is absorbed, how it's transported, how it's excreted. And the information that's important to us is actually the concentration profiles of the drug in the system. And then pharmacodynamics is what the drug does to the body. So in our case, Pramlintide produces plasma glucose after. So that's what's important to us, and this is directly affected by the concentration of Pramlintide, which we get from the kinetics. So now we go on to our methodology. So we just went through design and motivation. And then we had to get a base model of a glucose insulin model to then add Pramlintide to. So we obtained a modified Blocker model, which is this. What you're seeing right now is a compartmental model. And this type of modeling is a mathematical modeling approach that they use to model physiological systems. So
don't change it yet. You just take a moment, please.
Well,
As I'm describing it.
so what you're actually seeing is a minimal model. So this is using the least amount of parameters to get the best predictions of the system. So some of the compartments are actually physiological. So these compartments actually represent the subcutaneous layer. However, these compartments represent insulin action subsystems, and they're actually done used by fitting. So because it's a three-compartment, it's not a first order system. So then you add compartments to fit higher order systems. And this is what this three-compartment represents. And just a brief explanation of what you're actually seeing in this. So G1 and G2 are glucose compartments. G1 is the accessible compartment, so that's where we actually get the glucose concentrations from. And then G2 is a non-accessible compartment. And then here we have the slow subcutaneous compartment of insulin. And this describes the insulin's diffusion into the subcutaneous fat. And then here we have the fast compartment, and this describes insulin's diffusion into the subcutaneous, but because the subcutaneous layer is very non-uniform, it will hit the capillary or some easy access into the plasma. And then these action subsystems actually are how insulin affects glucose. So they're responsible for transport, disposal, and endogenous glucose production of glucose.
Well, can you go back for a second and just describe the difference in the arrows? So the dotted arrows, right?
Okay, so the bold arrows represent kinetics, and then dashed arrows represent dynamics. So as you can see, the insulin action subsystem, these are the dynamics, the endogenous glucose production, disposal, the transport. So after we obtained this model, we tested it to clinical data. So this was our fitting using placebo data, just a meal and insulin. And as you could just see from the graph, it looks like it fits pretty well. And then we use these two measures of goodness of fit, R-squared and mean square error. So R-squared, or coefficient of determination, describes how well data points fit to a line or curve. And then root mean square error is frequently used to measure the difference between values predicted by a model, specifically our model, to actually observed values, which is experimental data. So then we move on to Pramlintide intravenous kinetics. So we obtained this Pramlintide model here, this 3-compartmental model done by Cody, and we tested it to clinical data. So we used FAN, which I previously spoke about, they had a PK/PD model. So this is a bolus of 2 minutes, and this is a continuous infusion of 120 minutes. And so what you're seeing, the dots represent the mean experimental data, and the lines represent our actual model fitted data. So then we moved on to Pramlintide subcutaneous kinetics. And the first thing we did is we tried to adapt the subcutaneous insulin kinetics we found in our base model. So we replaced, as you see, they're both the same. We linearized it. So what you're seeing is non-linear and the reason why it diverges is because when a system is non-linear, it diverges from a linear system. And then we use gray box modeling to just find our initial values. Just find some values that gave us a good fit. And then we optimize those values to give us the best possible fit. And so this was our final model. It consists of 1 compartment. And then this is our fitted data. So what you're seeing here is the red dashed lines as actually standard deviation only from the mean of the experimental data. And then the blue lines are our fitted models.
I'm sorry, which one is the fitted model?
The blue lines?
Right, the red line is 1 standard deviation away from the mean?
No, just the standard deviation of the mean, well, of the mean data.
Yeah, plus minus 1.
Okay, so it's 1 standard deviation away from the mean, plus 1, and
Yeah.
there are 2 red lines. So one is 1 standard deviation higher than the mean and 1 lower than the mean?
Yeah.
Okay.
And then this is the predicted data. And the importance of using fitting and prediction is that you can fit any data. You can take any parameters and fit it data. But what's really important about a model and what gives it its backbone is predicting it to other data that you haven't fitted. So in this case, we fitted was it 50, 100, and 300 micrograms. And these predicts actually better than our fitted model, and this is a good thing.
What are the 3 graphs that you have? I can't really see.
This is 30, this is 100, this is 300. I'm not sure why the concentration is in
Maybe I just did not see it. I can't really
Yeah,
remember.
no,
Yeah.
And then this is just a step response to compare our intravenous kinetics to our subcutaneous kinetics. And it shows a delay of about 55 minutes. So subcutaneous takes about 55 minutes longer to get into the system than intravenous. So then we move on to pharmacodynamics. So first we correlated the parameters to Pramlintide mechanisms. So the first was, let's see that, EGP. So we correlated EGP to glucagon suppression in Pramlintide. And we also correlated UG, which is gut absorption, seen by this equation. And this has to do with both amyl delay and slowing of gastric emptying. And then also Kg, which we also equated to some sort of endogenous glucose production. And these are 2 pharmacodynamic forms. So both one is linear, one is a hilly head, which is non-linear. So after we correlate the parameters, we fit the parameters using the linear PD form to clinical data. So these are the 5 sets of clinical data that we use. WEO, which is actually Simon's insert data. It used 1 dosage of 60 micrograms over different periods of time during the meal. So at -15 a meal, at the same time as a meal, 15 minutes after meal, and 30 minutes after meal. And then FAM is the intravenous PK/PD model, and they also had a high dosage of 300 micrograms And Coltman was a study of pramlintide after 14 days of use, and it also contained a high dosage of 300 micrograms. Con was a study done on gastric emptying using pramlintide, and Thompson it's a study of pramlintide over 7 days, and also contains 3 meals, which is quite important to see how pramlintide affects the system during the entire day. So these are things we tested. So we tested the linear PD equation on BGP, KG, and T-NAPG. We also tested theta, which is a time delay on the meal, and then we tested these separately and in all combinations, and we fit these in together. So this is our best fitted model, and this included a meal delay, a transport delay on pramlintide, and then a linear PD effect on T-NAPG. I know you can't really see this well, but
That's all right.
okay. So here we show exactly what P theta is. So pramlintide is administered at approximately 30 minutes in. However, we don't see any effect of pramlintide until about 9 minutes after. So that's what P theta is. It's a transport delay from the time it's administered to the time it actually reaches its active site. And then here's when the meal occurs, when the meal starts to occur. So this is about 34 minutes, which is a delay on the meal that occurs. When changing T-MAPG, we noticed that there was a gap that occurred during meals. So to solve this, we came up with this equation, which is minusing the old T-MAPG, the amount of meal absorbed, and then the new T-MAPG, the amount of meal absorbed. And we were able to rectify the problem. And so whenever T-MAPG changes now, the same amount of meal is absorbed throughout.
What's T-MAPG maximum time?
T-MAPG is actually peak meal absorption time.
You should really, I think you should describe what's happening. That in the middle, you're changing T-MAPG, right?
Yeah,
So they should all be in the same place at the end, but since you changed T-MAPG in the middle.
Yeah, so we changed T-MAPG about here. And so T-MAPG is now a shorter time at this point. So this is why all of it gets absorbed so quickly. But not all the amount of glucose is actually absorbed. And then here, T-MAPG is actually extended to a longer period of time and more glucose is absorbed. And this occurs because a gap is created. So to compensate for this gap, we have to calculate the gap is correct it. Okay, so these are some of our predictions. So this is first prediction, that is a multiple meal at 10 micrograms. The top is a placebo, so this is only a meal and insulin, and then the bottom is meal insulin and pramlintide. And our prediction predicts pretty well. And then this is 30 micrograms of the same multiple meals, placebo and pramlintide. And this is 100 micrograms. And then this was another prediction of using pramlintide over 14 days, and it had placebo on top with pramlintide in the middle, and then these are actually pramlintide kinetics that were also predicted. So these values are for 30 micrograms, and this is for 100 micrograms. And you can actually see the correlation because if the kinetics are up, so our R-squared is 0.58, and a perfect fit is 1 for R-squared, and then a horrible fit is -0.2. So that's the worst fit possible. So our R-squared is 0.58, and this directly affects our PD R-squared, which ends up being a lot lower if you compare it to a good R squared like that, like 0.96, and with a better R squared. So this is our third prediction using 2 meals, first with Pramlintide, second without Pramlintide. This is also a prediction to the placebo. This is 30 micrograms. This is 60 micrograms. This is 90 micrograms. And finally, we did a comparison of our model to Planck's intravenous model. This is for 50 micrograms, and as you can see, our model does better in Planck's for 50 micrograms. 100 as well, surpassing Planck's. But then for 300 actually does worse, and at this point we think there's some non-linearity that occurs within the system. And we think this is why maybe our model may not have been done so well at high concentrations. But it's also good to note that such high concentrations aren't really used of Pramlintide. So this is our final model of everything. Dotted lines represent PD, blue lines represent kinetics. This effective compartment represents the transport delay, P beta. N cases, the delay occurs here, and then also a linear PD that occurs on Tmax stream. So for future work, we hope to use this model to improve and optimize current dosing approaches, test different dosing approaches such as a dual dose bolus, as seen here. It combines a normal bolus with the infusion. And then also to test different control approaches. So to test pramlin and insulin at the natural ratio that occurs within the body naturally. To test Pramlintide as a fixed disturbance, such as using a stimulant pen, which is found commercially with only insulin control. And this is actually what was done in the Weinzimmer study that I told you about. And then also Pramlintide and insulin both adjusted via controller, and then finally testing different controllers. So a proportional integral derivative controller versus a model predictive controller. So just in summary, a proportional integral derivative controller uses changes the input of the system. So you give it like a certain levels of a certain level it has to maintain, and what it will do is it'll adjust the input of the system to try and maintain that. And then the model predictive control, it actually can predict time points into the future and adjust accordingly. And well, the only difference between PID and MPC is that PID doesn't have predictive capability and MPC does. So in conclusion, promising results lead us to believe that the addition of Pramlintide to the artificial pancreas will alleviate common postprandial problems. Pramlintide will allow for a simple controller, which is not computationally intensive. This will allow the model to be used in current technology, and also create a system that can restore tight glucose control in insulin-dependent diabetes mellitus patients. This will reduce complications and improve their quality of life. So, references. I'd like to thank OGT for providing me funding. My supervisor, Dr. Brian Osterheide, my co-supervisor, Dr. Natasha Ramkissoon, and my collaborators, Dr. Wade Beckett, Dr. Cesar Fleury, Dr. Freddie Cameron, and Dr.